All right. So, what are psychological disorders? So, in general, the way we view psychological disorders are dysfunctions in behavior that are considered atypical, disturbing, maladaptive, and unjustifiable, right? Now, when I teach psychopathology as a course, I use the 4Ds as a frame of reference: deviance, distress, dysfunction, and sometimes danger, right? So, deviance is what we mean by atypical, right? So, this is considered not within the norm. And when we compare you in terms of what's considered normal or abnormal, we compare you relative to the community, right? So, that's important to understand that if a person comes from a certain background, we're not going to uh, judge them based on another cultural value system. So we look at what are your values, what is your community that you belong to, and even considering your culture and the community you belong to, is this considered atypical? Is this considered abnormal, right? Another thing that is important to understand is that what's considered acceptable or unacceptable, that does change from time to time, right? So, uh, our definition of psychopathology has shifted. And in fact, because what is considered atypical versus normal, because it changes, the DSM always has to be revised. And there are some disorders that were in our manual that have been removed, and then there are some that have been added. So it's important to understand that what's considered normal or abnormal is dynamic, it's in flux. So there has to be some level of distress, right? So when we talk about distress, typically the distress is to the person themselves. So whatever condition this individual is struggling with, that they are bothered by it. Now, in some cases, the people who are bothered by this behavior can be those around the individual. For example, if we're talking about a substance use disorder, right? So when a person is abusing drugs and alcohol, it's possible that they lack the insight as to how it affects those around them. So maybe they'll say, I don't have a problem, right? And because they don't believe they have a problem, they're not bothered by it, but it causes significant distress to those around them. Now, dysfunction means it has to be uh, maladaptive, or in some way it has to interfere with day-to-day functioning. When I say maladaptive, in one domain or another of your life, it causes problems, whether it be in your romantic relationships, whether it be family relationships, whether it be at school, whether it be at work, whether it's legal problems, and so forth. So the disorder itself has to have some dysfunction, it has to be maladaptive. And we say unjustifiable is because it cannot be better explained by some other biological factor or some cultural value system. So when we look, other people look at this behavior, uh, it doesn't make sense as well. Now, the one D that's not there is danger, and the D of danger is is present in some but not all psychological disorders. So if a person is struggling with depression, there are higher rates of suicidal ideations and death by suicide, right? So we have to be mindful of that. With ADHD, the risk of suicide is much lower. Now, there is a greater risk of other bodily harm, especially when we're talking about a hyperactive subtype of ADHD, right? But so the danger, it has to be some significant danger to oneself or others. In some conditions, like schizophrenia, it is possible to have homicidal ideations, which is the thought of, killing or harming another person. And that danger to another person also has to be considered. But in the vast majority of psychological disorders, danger is not present. So, okay. So that's what we mean by psychological disorders. I also want to make a distinction between the concept of neurosis and psychosis. When we talked about the different traits of personality, we talked about Eysenck and their distinction between neurosis and psychosis. But as a reminder, neurosis is a term that has been around for centuries, and it's meant to describe some level of a psychological imbalance that causes distress. But it's very important to understand that in neurosis, there are no breaks from reality. There's no psychotic states. So the vast majority of psychological disorders are neurotic in nature, right? So outside of psychotic disorders, which is a handful, we're dealing with neurosis, right? So things like anxiety or depression or phobias or OCD or ADHD or learning disorders or eating disorders, these are all neurotic in nature. Psychosis is a more restricted set of disorders where your sense of reality is impaired. Your thoughts are impaired. Your perceptions are impaired. And generally speaking, the way we define a psychotic episode is when a person is detached or loses contact with reality, right? So they could be experiencing hallucinations, whether it be hearing voices or seeing things. They could have delusional beliefs, right? So irrational, persistent false beliefs. And there could be a whole host of motor and thinking problems related to it. So it is a select handful. And we say less than 1% of the psychological disorders in the DSM are psychotic in nature. And you might say, well, why am I spending so much time on this? The answer is there's mental health stigma. There are a lot of people who will say, well, I don't want to go to a clinician. I don't want to go to a therapist because I don't want to be perceived as crazy or psychotic. And in reality, the vast majority of conditions have nothing to do with being quote unquote crazy or psychotic. So 99 out of every 100 cases, we're dealing with a person who's struggling with some kind of general distress or neurosis. Now, there are different models to explain mental illness. In the history portion, there is a discussion about the supernatural model, which links demons, spirits, and the moon, witchcraft, etc., to mental illness. But that fell out of favor, I want to say, in the 1700s, roughly. The medical model was a competing model with this supernatural model for thousands of years, millennia. But the medical model specifically suggested that mental illness are like other diseases that have physical causes. They can be diagnosed, they can be treated, and they can be cured. And it's very important to understand that there is an emphasis on physical causes. And we're going to show a third competing model of mental illness called the biopsychosocial model, which goes beyond just the physical realm, right? So, similar to other physical impairments, mental illness can be diagnosed based on symptoms and cured through therapy. So you're going to hear, like other conditions, the term etiology, which are the causes or risk factors for the development of a disorder. Diagnosis, which is once you have a certain number of symptoms, we have the ability to identify a specific condition. We also have the ability to do what's called a differential diagnosis, which is to distinguish between one condition and another. So we have the risk factors for a disorder, we have the disorder itself. Once we come to a diagnosis, we have the ability to treat that condition, right? So treatment is how we deal with whatever diagnosis we come up with. Now, the medical model, which is an older model, because it's similar to other medical problems, treatment occurred in a psychiatric hospital, right? So if you had a physical impairment, you would go to a doctor, you would go to a hospital. So same thing with mental illness, you would wind up in a psychiatric hospital. Today, not so much, right? But we're also not governed by the medical model exclusively. But there was a treatment, a series of interventions that were designed to address whatever the diagnosis was. And then prognosis. Prognosis refers to based on whatever condition you have and whatever treatment we're employing, what your response to the intervention or treatment will be. So prognosis is how likely you are to get better. So we're forecasting the disorder. So people might have a really good prognosis, for example, with anxiety disorders. People might have a fair or average diagnosis with certain learning disorders, right? And so forth. So we would say, looking to the future, what's the likelihood of a person getting better? So that's prognosis. Now, I said to you that there's this third competing model. So in history, we talked about the supernatural model. We just talked about the medical model. Now let's talk about the biopsychosocial model, or what we are now starting to refer to as the biopsychosocial spiritual model. And I'll explain to you what I mean shortly. So the biopsychosocial model acknowledges those biological influences that the medical model focuses on. So yes, your genetics, your brain structure, functioning, and chemistry plays a role. Evolution plays a role. All of these, heredity in general plays a role. All of these things are biological. They can influence the development of a disorder. But if we were to only look at biological influences, we would have an incomplete picture of mental illness. So this model says, hey, there are also internal factors or psychological influences, and there are external factors or environmental factors like social, cultural factors that play a role. So when we talk about psychological influences or internal factors, we're talking about how you cope with stress, your experience of trauma. We discussed the concept of learned helplessness, and in terms of how one's mood affects how we see things in our environment. So all of these are internal factors. Now, similar to biology, it's not a full list, right? So personality plays a role as a psychological factor as well. And then social or cultural factors, environmental factors are what are your roles, the expected gender roles or social roles, right? What is considered normal or abnormal. I had the privilege of doing my internship at the Hamilton Madison House, which is in Lower Manhattan. And when I did my internship there, it was one of two Asian bicultural centers. So the focus of therapy was designed to create access to care within the Asian community. And when I say Asian community, We had a Chinese clinic, we had a Japanese clinic, we had a Korean clinic, we had a Vietnamese clinic, and then we had an English speaking clinic for the local community in general. So it was designed to create access to care. However, one of the things that we saw with traditional um, Asian communities is before coming to a psychologist, they're more likely to go to an Eastern medicine doctor or their primary care physician because there is significant mental health stigma, right? So if there is a belief, hey, maybe there's something going on or something wrong, well, I will go to uh, a person who provides Eastern medicine, or I will go to my primary care physician because clearly um, it's something physical. However, when the person goes to one of these two treatment approaches, the condition doesn't go away. So it's not uncommon to get a referral from a primary care physician or from a person who does acupuncture or herbal medicine or osteopathy, right? And they say, listen, uh, what's going on here is not physical, it is a psychological condition. So notice how one's belief about what's considered normal or abnormal, one's belief about mental health in general will affect the utilization of mental health services. So that is the biopsychosocial approach. I'm going to stop the recording here and then we're going to talk about the DSM in general in its own recording.